Good evening, friends online. I am thoracic surgery Ne and Dr. Wang Ming of the VATS official account. Thank you for your continued support and encouragement. Today is the second phase of our official live broadcast. Very lucky. Invited to the first affiliated hospital of Zhejiang University. Director Liu of thoracic surgery explained to us, single port thoracoscopy, sleeve of the lower lobe of the right lung, sleeve resection of right lower lung, in all bronchial sleeve incisions. It is one of the most difficult sleeve cuts, because the middle lobe bronchi is quite different from the diameter of the middle bronchus. There's a natural angle, stenosis or angulation of the anastomosis, and the appearance of proximal cat ears. They are all common difficulties and pain points in surgery. Please invite Director Liu today. Share with us experience of sleeve resection of right lower pulmonary bronchus. Welcome to bullet comments in the live stream. Interact with the Thoracic Surgery Network group. Ask questions and provide valuable feedback. Mr. Liu. So here we go. Hey, okay. Can you tell me first? It's this or right sleeve resection. Is it okay now? You heard me right? You can hear it. Okay, there's no way. Here it is. Anyway, there are some tasks. Which one is the first? Yeah, sorry. Take a phone call or something. Well, what about the lower right sleeve cut? We are also a source of inspiration for this. Some experts do this better than me. We can't really talk about too much experience. Just of this. Did you do some? Did some. Then I'll have some of my own little experiences. Then share it with everyone. And we started the conversation. We also hope to have more experts. Can you join this? In this activity of ours. Then put your own experience. And then they communicate with each other. There's a process of learning from each other. And then, anyway, every time I participate in this kind of surgery live broadcast, during this surgery seminar, I can learn a lot from the experts. This skill, or something. So I like it very much myself. I have the opportunity to learn this from you today. So what about today? Here it is. With this little personal experience. This report is the main one. It's not about what to tell you. This new experience. What do you mean by that? Not enough experience. Well, the big names in our country who do this kind of surgery are from it. Right? So it is. Let's be humble first. Please forgive me where you were wrong. And then people pointed it out. Then we just have to learn more. Opportunities for correction and progress. Okay. So let's start with this surgery video. Anyway, there is a part in front of it. And what about our patient? Let me introduce a brief situation. She's of 44-year-old young woman. Cardiac treatment. The positive one is that this is 21 checkpoint mutations, and did 2 courses of chemotherapy. What about tumors? There's basically no retreat. And what about the early stage? Because considering this, is it chemotherapy or targeted drugs? And we were hesitant, just because I used to after taking the targeted drugs. Some patients are particularly elderly, so still. Chemotherapy was specially given to this candidate. Turns out chemotherapy doesn't help. The patient's tumor didn't shrink. Then the lymph nodes are still quite tight, because it was taken into account before surgery. This person may have severe lymph nodes. I am afraid that after taking the targeted drug, the lower right is not easy to divide. This is why I gave him chemotherapy. And after the chemo, it was pretty good. Very good score. You see this? And we started by doing 7 lymph nodes, because lower right. Our general idea is to do it from the back to the front. And the general idea is still to do it from the back to the front. So what about doing it from the back to the front? Well, subcranial lymph nodes. What about subcranial lymph nodes? It's RL. Basic entry ideas with director Wang Ming. He is in front. It's kind of the same idea that his video shows, is to separate the lower lung ligaments. What about after separation? This whole lower lung, between esophagus and the inferior pulmonary veins, the gap opens. The gap is very large. What about after playing bait? Do the esophagus first. What about after the esophagus is done? This nourishes blood vessels. You see here, one by one, these nourishing blood vessels. Take them all. Take this one. The electric hook was broken. And what good does that do? Just nourish after the blood vessels are broken. This lymph node bleeds a lot less. Because a lot of these agency managed patients, his lymph nodes nourish blood vessels quite well. If you start from this side first, do it from the trachea side first, sometimes make a little bit of blood. Is it also dirty? This makes it uncomfortable to sit. And what about here? What about his lymph nodes? It is completely imprisoned with the trachea. So in this place, yeah, I sat for a long time. Just take this electric hook and hook. What about the electric hook? And this place, it's just that sometimes after the tumor is in prison, it's not big and has that gap to hook you in. It's just that you might be looking for this. Just find a soft pinch for the persimmons first. Which place is good to hook? See if you can hook it in. Hook a way out. So we followed the trachea too. Check these good places. But a lot of times it ticks around. And what happens? Do you still have to go back to that place that can't be hooked? To this place that can't be hooked? I feel it myself. Maybe it can't be hooked. Why are you grinding around here? It may also be difficult to find a way. So in then, it's still like open surgery. Well, what? Just take this electric knife and burn it and push it. Burn it and push it. That's it. Or take scissors to cut. After cutting, bleed and then squeezed again. Scissors squeeze blood. Then I often face this kind of situation myself. The bureau manages lung cancer. Is this the case? It's like this, and it can't be hooked a lot of times. What about the ultrasonic knife? This place is pretty hard for me to do myself. Sometimes there is nowhere to clip. It's all in one piece. The ultrasonic knife seems to be. Anyway, in my opinion. Although the knife head on the front end of it, it can use energy to give it. Make way for it. But it's still not as fine as an electric knife. So a lot of times I still like to use an electric knife. Director Wang, you are ordinary. If you encounter this kind of dough, the lymph nodes are particularly dense with this prickling. What kind of equipment do you prefer to use, or in what way to separate? I'm generally with a very thin electric hook. Like this, it just doesn't feel good. In this case, I could probably pull it up with a pair of pliers. Its lymph node forceps isn't its grip stronger. After catching, use an ultrasonic knife or cut with scissors. Well, what about this place in front of me? It just anchors this place. I want to put this with the pericardium behind it. See if there is a gap that can be separated. So all the time you look at the tick here, every time, you can still tick a little tick tick. Hook it to the back, it doesn't feel like it's moving. So what about the back? So I started trying that with a pair of pliers. Teacher bullet comment, someone asked which rib is this? Where is this incision located? This patient? This patient should be. If memory serves, it should be. Hey, I kind of forgot about this. Anyway, it's not the fourth or the fifth. If we are in the lower right anyway, the fifth most when it is simple. Fourth most complex. Hey, usually just this one. Wait a minute and see how the gun is fired. What if the gun was shot at this end? That's number 5. What if the gun was shot to the side of the foot? And that's number 4. It just depends on how this vein got into the gun. A question from the audience. The tumor is located in the right lower bronchial opening. Many doctors did a direct lobotomy. Simple and rude, reliable cutting edge. What do you think about this? If the lung function is good, okay. If the lung function is good, I don't think there's anything wrong with cutting more leaves. and the patient is safe. Surgery is convenient and fast, myself and sometimes me too. It's not that many of them are directly selected for sleeve cutting, so can I. And make a middle and lower lobe, make middle and lower leaves. It's very convenient. Hey, you see, this is also mine. I got it in the back, and I had no way to go iron to pick it up. My pliers are very useful. I found the manufacturer to customize these pliers myself. Very small. It's a very small right angle. You see, it's incredibly small. Double jointed. The front is pretty sharp too. I think this method of pulling is particularly good because there is no grip under the endoscope. For regular simple ones, it's okay. This is so tight without a grip. What tension is this? Michael, tension is not enough operation of your main instrument. It becomes very difficult. Yes, and then the following words are not tipped either. Actually, this place is quite hard to hold. I'm so still. You see, I just take an electric knife and burn it little by little. Burn and push. Burn and push. It's actually quite tight if you want to take it. If you look at this kind of take, it will. Sometimes I feel that the action is actually too big. Your burning action is very handsome. This ironing action is very handsome, but for newbies. So this is a slightly dangerous move. That is, if you do this action, do this action. I'm doing this. You are so hot. Okay. To do this action, you need to dissect this. Very understanding. It's front, rear, left and right, especially what's below. So this is a partial dissection. Can you describe it? Here's the bronchus. There's the pericardium in front of it. Then if you accidentally open the pericardium, you might encounter the pericardium in there. Open it and inside is the left atrium. Be careful then. Did you open the new bag? New package or layer protection? That new bag can be ironed. It's okay as long as it's not ironed. It's usually fine. It won't work if it's ironed. So this place is sometimes operated. Also be careful. Don't poke it in the heart bag. Pericardium sometimes. The pericardium may be very thin after it is eaten in prison. Are you poking it in your heart? Sometimes it just pokes the structure inside that pericardium. Hey, it's an electric knife instead. It is more convenient if your heart is broken. Does it come out of the water naturally? Pericardial effusion. The water will come out, but it will not be much. Put the pericardium together with the left atrium below. Burn together. Not likely. I think electric knives are relatively safer. If you are super knife, you have to hide this pericardial side. This is the lymph node at the very end. And that's where they normally have nourishing blood vessels. Look at this place. We start it there. There's a little blood vessel on it that keeps going, right? I didn't see the esophageal side. Pointing around at that time. Pointing around. But it's not good. How come? It's hot there. Take a look later. It was marked on it. That's boring, right? The above is in. It turned out to be still under the finger. Did you just see it? There was one on it, haha. Copy the following. After being imprisoned, this school is almost done. Just this place. You see, we all hold this top one by one. Then take this safe. Take this knife. Just burn this head off little by little. Yeah, it looks pretty clean. But what actually? It's just behind the trachea here. Just between the bulge and the pericardium. Okay. The place to go further is in the direction of group 24. Between the carina and the pericardium, in the direction of group 24. It actually has one lymph node. It's going up in that direction. We often do this. This place will be a bleeding, nourishing vessel. Sometimes half a lymph node is left here. Right? Do you feel it? Just this half lymph node. This, right? Well, that was my surgery yesterday. The live demonstration is to participate in Professor Sh. He did the live surgery. Demonstrates a right upper lobectomy followed by access. Hey, right upper lobectomy. He finished the trachea. This lung has all been taken off. This upper right bronchus, he just has one left. Is it one? Because the upper right leaf was cut. And then there's the right superior bronchial stump. And this right medial bronchus. Here's one left. He's got these soft round pliers. Pick up this right middle bronchus upper right. And you look back and forth. What about an aspirator? Push down this pulmonary artery stump. Take a hook and end to this from front to back. Take this lymph node in front of this tracking process. Or sweep it away. What about this lymph node? Will be directly connected to this 2 or 4 group. Hey, then what? He made an analogy. He said, what about this place? Just like in Zhejiang province. It belongs to the intersection of the 4 provinces. Ah, he's right. He said it depends on everywhere. Relying on the 7th sun again, relying on this 4 suns again. Yeah, and then it's hard to clean. Tao is often missed. And I said yes. I said I often keep a small half of this place. So that's it? And he said, well, what about this delayed patient? It doesn't matter to ordinary patients. You don't have to sweep it. Then the patient who was delayed was still swept away. Sweep this one, don't worry. Because it is very likely that there are some 2 or 4 groups. This lymph node is from these 7 groups. Did you go up slowly like this? It could be a transit row. I don't think so either. Because there are many patients who swallow. You want to transfer to group 7 first. It's probably just going through here and doing 4 more circles. Right. So I learned from Professor Shi again yesterday. How? Then what about after this lymphatic scan is done? That's what we do behind this. Is this the location of the trachea exit? I just did the trachea exit. Just like that. Get this lymph node in the lungs right. And then there's liquid cracking. It's the liquid crack in front of it. Usually we are all here. This place where the 3 leaves meet. Find the artery right. Then along this dorsal segmental artery. Between this upper and posterior lobe. This place. Go find that signature lymph node. Lymph nodes found. You can copy it out. However, it is still relatively fixed here. Just this place. It's nothing more than. Some people develop particularly poorly at night, possibly handcuffed. It's easy to bleed. Or how about easy? Most of it. This you just follow this artery in. And find that signature lymph node. Take it out between the lymph nodes in the lungs. Generally, it is more convenient. Brother Ming, how did you get it? Just this point. Same. I think between this lymph node and the lung. This is very important. Now, if you flow this node into the side of the lung, between the lymph nodes and the arteries, if you take it out, you shoot it. The lymph nodes are pinned to the lungs. To avoid this, you still have to tunnel between the lymph nodes and the lungs. Right. Well, this tunnel opens. Yeah, that's right. The people here are relatively smooth. It's easier to find this tunnel. Sometimes it doesn't go well. I can't find it. It's bloody for a long time, right? Would it help to make the entrance bigger? It's safe. The entrance is generally relatively small. I use an electric hook to enter it, or the Great Wall knife to cut it bigger. In that case, it's easy to sew later. If the entrance is larger, you're going along the sheath. Looking for this entrance, right? Freeze the level of the arterial sheath from the inferior lobe to the dorsal segment, right? Between the upper leaf and the posterior branch, right? If the dorsal segmental artery can be exposed, and this epigenetic artery, then everyone is safe. Sometimes the 2 arteries. It's the dorsal segment and the epigenetic arteries. Sometimes not much. It's pretty neat. It's a mess. Right? Yes. Okay. And this place, it's the middle lobe and this lower lobe. This lymph node between the middle and lower lobes. This person is a patient under the supervision of the bureau. Because what about our lymph nodes? They're still more careful and patient. Give it a point. And finally, you shave it all off. Well, this lymph node is hard to shave. Don't you think, sir? Yes, this guy is lucky. After I shave it off, and it didn't go any further down the roots. Some people will grow a long one from the back of this artery. There's another artery in front of that branch. You mentioned this last time, right? It grows between the lateral segmental artery and the bronchus. This lymph node between the middle bronchi and here. This guy is a little bit of a doornail. There are some doornails. It's not just this transfer problem. It still feels like a small doornail. So there is also a up one at the back. Posterior longitudinal artery and the lymph node between the trachea and the upper lobe. That lymph node. This is hard to scan. Yeah, just stay there. I also gave up on that lymph node a lot of times. I feel like hollowing it out completely. It's also difficult. How do you usually do it, that place? Would you choose to hollow it out? You, for example, you make the lower leaves. Weigh this when making lower or middle leaves. Do the next layer. So if you want to scan that lymph node, it's like making the upper leaf. Give it the upper lobe artery, everything. Hollow all around. After dimensionality reduction, it is to dissect from multiple angles. After that lymph corner is loose. Maybe from a bigger hole. Can pull it out. Okay. You flip back and forth, don't you? Yeah, flipping around. You say the back of the forearm of the shoulder and the back of the upper extremity bronchi. Leak there out of that lymph node. Give it enough relief. After that, and then from that back upper extremity between the artery and the bronchus, loosen it up here. Maybe if we talk about robots. Maybe you took that plier slowly. He can also take it out. Yeah, those holes. Maybe I think so. This place might want to be bigger. Is to be able to pull this lymph node back. Pull the lungs forward. Yeah, and you can also take the aspirator and press the posterior ascending branch artery firmly. Okay? Theoretically, this place would be better exposed. Do you think you should join teachers from before and after? I think it might be easier to switch teachers. One of its lymph nodes. The hard part is getting it out of a hole. Can't fully expose it all. You may only see 2-3 of it. Then go from there up there. You can see 1-3 from the front. You completely loosen the front third. And you can't take it out. Then come back. Look back from this 2-3 place. Hey, it's already loose over there. If you pull it, it may be pulled out. Right. Others ask if there are special equipment for lung segments. We all buy it from the hospital. Sometimes I customize it myself. I especially feel that it is easy to use. Have a personal need. We just severed the vein, didn't we? Yeah, if the vein is broken, that's how we are anyway. If you look at it, it should be the 5th intercostal space. This cut is also going forward, right? Well, this place is tight. This place. I did it. It feels tight. So I go up and down. Do you want to cut off the artery after the vein is severed? It's divided up and down, including especially the dorsal part. It feels very narrow. It feels very narrow at first. Very narrow. I'm thinking about the back section. Anyway, this length, we'll see if it can be done. Tie a knot. Tie the dorsal section in a knot first. Maybe the whole thing will grow after tying it up. Oh, I had this idea at first. Okay. The main exit is particularly tight and can't get out. So in the beginning there was a tick here and there. I want to untie the back section first. Well, you said. No money. I'll take this. Otherwise, you will pull up the leaves. It is possible to pull up the leaves. Generally, when the dorsal tension is relatively large, I dare not let the magician invest too much money. It's this dorsal segment that I damage myself. Yes, sometimes he stares at the back part. If I stare long, I will panic to death, so I tell myself a lot of times. It's safe to pull up the leaves. Your upper leaf wards. Anyway, there's a bronchial glaring there. Yes, the pots can still be stretched. I have been injured by broken pull several times, haha. Well, I just didn't expect it at all. Hey, why did you pull it? Why did it bleed in hematoma? Oh, unless. I'm still more cowardly. You're basically doing the surgical style. I'm in a more cowardly style. And what a painful realization that is. They must have suffered a loss. Then the valuable experience. There's guts. I'm a coward. Be careful. And here. And it's a high quality of life, right? This blood pressure will not be high. Stable blood pressure. However, then after dividing it, I found that the width is okay. Width is okay. And the underlying lymph nodes were okay. So I'm just going to take it from here. See if you can pass it. The result is over. After that, I expanded the feeling a bit. This width is okay. It should be possible. Just pass the gun. All the feeling of passing the gun is relatively narrow. So what? Just want to get the silicone tube silicone. Pour the silicone method. Pour the silicone law. As a result, dislocation. Silicone dough is not so good either. It took a long time. You see, you put it here first. I couldn't get out, and then I switched sides. Turn this out slowly. I don't dare to force it. This silicone. That's the problem. It should have an edge, you know? Okay. Right, it's not progressive from thin to thick, right? That's the only tube for him, right? Is this actually a drain? That's all there is to it. Then you clip the red catheters on both sides. Would it be better to clip both sides? My two squash. Same with the flattened ones. Flattened, he's still a rib. Yes, so the perfect silicone tube is a line. Lead a thread. It goes from thin to thick. It ends up being a tube. Yes, this one. Just come over and cut that head right. Cut off the thin head. Yes, cut the thin head right. Then you're cool. So is this necessary? See what I'm looking for then. There will be new product research development. What will happen next time you change your head? Put that end there. Would it be better to hold the blind end? That head is also thick. Oh, that end is also thick, right? The key is the innovation of the pipe. Well, we can rest assured about the pipe innovation. Oh, I'm already working on it. I'm going to make this pipe for it. I'm already working on it. Okay. Then we scan the lymph node. Mainly this lymph node looks uncomfortable. Or do you want to sweep it down? After sweeping it down, this is... Sometimes it spills lymph. Does it spill down? Anyway, I feel comfortable. And these lymph nodes are pretty nasty. It's just that I don't feel good about myself. Many times this. Hey, this place may not be good if the technology is exposed. Video of this long pull. Hey, if you reflect, just. Bad technical exposure. I don't know where this lung has gone. I don't know if it was pulled or not. Maybe he didn't pull it. I'm just doing it myself. Right? So sometimes watch videos. It's pretty advanced, actually. Right? If you watch your own video, you will feel that when you look back. What the hell are you doing? I didn't know what to think. Yeah, we're all doing it. Right? Even after all these years. So I'm not a gifted player, you know. I think some of them have lower requirements for assistant. You can do anything. I'm an assistant. If I don't get it right, I'll keep adjusting the exposure. This time is spent exposing. Maybe half the time of an operation. If the assistant writes you all the time saying, hey, which way to turn, which way to go, then you belong to the comparison. This is the better one. This line of thinking, the idea is absolutely correct. Feelings of obsessive, compulsive disorder. I know I can't hold it well. I'm sad. I think so. Sometimes you have a sort of make-do mentality. You know, a high. Okay, almost. All right. Why don't you come down and do it? When it turns out, let's just start, we'll make do. And finally, it didn't quite fit. Maybe it took time up front. Bucking around here, however. In the end, I have to come back and expose it again. If it is not exposed well, it cannot be done. Just a lot of times. Wasted time going back and forth. So say this, the key issue is a foundation exposure is very important. Very important for basic exposure, and you can't compromise. You have to spend your time on exposure like Ming, can't make do like me. How hard it's okay. Hey, okay, almost lying, that's it. Yeah, that's it. If you can fix the assistant level is very high, then this phone is very comfortable to make. The assistant can't do it. The assistant is either very tired. I've had the sleepy assistant before. You can't see it at this point at all. Or his hand loosened as soon as it was done for him. This is really uncomfortable, is if you can move your mouth. It's better than doing it. He can hold on. That can last a while. Some are just right after they move. I don't know where it went. In most cases, yes. Can't expect to shoot. Because a lot of times, like the Iron Battalion of running water, the soldier of running water, it's all regulation. Rotate this. Right. And there are all kinds of teachers to learn from. What? It's very short, Theum. Well, this run in takes time. Sometimes even if our running in is good, we go back. Here's a couple more. Some directors are. I haven't seen this yet. My assistant is actually okay. My assistant at least holds the mirror well. It's the same habit. You're all looking straight ahead. Yeah, this is one of our graduate students. Helping with the mirror for 2 years. Helped very well. And then the surgery. In fact, he also has his own understanding, including the order of surgery, these ideas, etc. He understands. The gold medal mirror holder is, in fact, many times I feel that. You said surgery. What do you want? How high a degree? I don't think it makes sense. This thing is a job. That's how practice makes perfect. You give him enough opportunities to exercise. Do you care about the master's student or the doctoral student? She's an undergraduate. He can practice. And this place, that's where the tumor is. Flinched. Partial retraction. This is the lower right dorsal opening. And at the beginning? What about this lump? It grows in the right middle bronchus. So what happened? We turned to this after chemotherapy. We turned to this lower right bronchus. So we're going to start right here. Cut it. What do you want to see? How far is this cut? How far is it under the? And cut it out. Cut it out and found 2 problems. One, this side is actually very narrow. This place, you kind of sew it back up again. I'm afraid it will be narrow. And what about the far end? Also very close. I feel it myself with the naked eye. It's positive. And of course, last and first, freeze pathology. I actually reported a negative. We just sent this directly. After picking up the cutting edge of Yuko, it was sent it to me and reported it negative. But to my naked eye, it was a tumor. Maybe the chemotherapy just flinched. Killer. Anyway, I'm still worried. You see the whole dorsal segment here is locked. So let's just put on a show later. There is a question on. That is a plain incision of the right inferior bronchus. If the margin is negative, direct bronchoplasty, will there be a high tension? And the problem of narrow angulation of the anastomosis. What are the countermeasures? For example, cut a fish mouth and sew it up. Mainly, I think it's the hole. Of course you can sew in a place like this, but how narrow is it after sewing here? Because a lot of times, the opening of the dorsal trachea and mid-leaf is actually a relative relationship. Just these two are just right on each other's side. Basically not much different. So what about this one? You directly break your back. If you were cut by Kaigen, then you basically don't. Not many places do so. After sewing, of course, you are like this, can you sew? If it can be sewn, it may be narrow. It's embarrassing when it's narrow. Then you said it looks like the opening of the middle leaf and that. The opening of these pipes in the middle of the right main and right is like this. Is it equivalent to a longitudinal seam or a longitudinal seam? Would it be better if it was vertical and horizontal? Just along the longitudinal seam. I feel so far away. Can you pull it through the longitudinal seam? Didn't you finish pulling a big corner? Right, the corner is so far. I'm sure the entire lower right opening is so far away. It's just a long time. Right? So here we are. I'm sticking to this lower right heart opening. Cut all the way to the dorsal opening. It's a long cut. So long? Will it be good to cut a fish mouth? When cutting a fish mouth? Yes, my understanding is the V shape right. Then get the sides up again, right? Would that be better? I don't know. I've never done that. I make my own V-shaped molding. It always gives me a sense of tension. Indeed, this is not as good as. I'm not a big fan of the V-shape, because I feel it myself. You're actually only 3 stitches and 4 stitches worse than the sleeve cut, right? Yes, it's the bottom layer. Almost. Well, but this bottom layer is the trachea. It's cartilage, it's so hot. Well, you're going to boil it hard and rivet it into this. Stick it on right, it's hard down there. You rivet it hard and rivet it into one by one. This one has high tension. Yeah, so I sometimes feel like, if the tension is so high, you should cut your sleeves and feel at ease. The sleeves are at least supple. You can sew whatever you want. Yes, the tension of the end mesh is definitely less than that. Right. In fact, what you are doing now is the work of loosening. Release the right main bronchus and this middle lobe bronchus. In fact, I have already made up my mind at this time, because when you cut it off it feels too close. This edge. Even if it comes back negative, I'm worried. Still want sleeves. Okay, do professors give themselves hands on opportunities during graduate school? Of course you can. But most of our graduate students are majors. All majors rotate. You need to know the rotation of thoracic surgeons. During the major, I stayed in my department for more than 2 months. On other hands, on opportunities are there more than 2 months. I haven't understood the mirror yet. It's the turn of other departments, right? Now, when we were in graduate school, completely different, our time. In the vicinity of 2000, I went to graduate school. Don't have too many hands on opportunities. Where's the rotation? No such thing. They all work in their own department. It's all clinical. Or foundation. No one does the basics. They're all doing clinical work for 3 years. In 3 years, you can basically open any knife. We were graduate students in cardiac surgery back then. When I graduated with my master's degree, I will see if the house is missing or not. So this. It's different now. Rotation now. Standardized training. No way. Teacher Lou still has questions on the bullet comment. The lymph node between the right inferior bronchus and the right inferior pulmonary artery. What to do? Cut the bronchi. The lymph nodes between the lower right and right pulmonary arteries are immobilized. If you can't tell the difference, it means the thorn is firm. Stab the trachea firmly. Okay, you must be cutting the trachea. What if you only need this trachea without a sleeve cut? You can leave it a little longer and cut it. You can sew it after cutting, right? Generally speaking, between the trachea and the artery, it doesn't stab it directly. If it is stabbed firmly in the middle, it has a doornail. Lymph nodes, although it punctures the artery, but it's also a protection for you. You cut along the trachea, and between the lymph nodes, it's very safe. Basically no bleeding. That's still risky, this, because after all, the back is the artery, in case you tear or cut this. So it's an artery. When the artery is blocked, it is very important, right? If you take out the leaves casually, then you can pick it up at will, right? Yes, it's generally for safety reasons. What about this time? Usually go first, after walking, then pick it up and it will be very dashing. Yeah, pretty drastic, right? Finished picking it up. If you don't go that way, jump over there. I fuck that hard. Then it can't be drastic. Director with very high surgical skills to make a big difference. General directors like us belong to. I don't know what to do. In fact, sharpen your knife and cut firewood by mistake. This blocks it. What about this place? It didn't take much time. Yeah, well, what about this place? It's the extensor posterior. A lymph node between that dorsal segment. These lymph nodes look a bit like doornails. Then he ate very well. Also like transfer. I don't know if it's still a transfer or not. So we thought, let's do this first. Do it and find it hard to die. Copy knives, nothing much can get in. And then, what, an ultrasonic knife? Electric knife, slowly sharpen, and think about it later. Here it is. Would you have to dissect this epigenetic artery first? See the epigenetic artery. Then it might be a little safer than Anne. So I went back to dissect the epigenetic artery. Hey, then you see this place is very tight. It's pretty solid. This is the sheath on the outside. It's kind of like this kind of door stud feeling. Just the sheath, such a thick sheath. And this, look at this after it burns. It's because it's really thin. It's really based on the strength of breastfeeding. Think this is difficult? Is it because it's scrap-free? If there is any way to get this lymph node, provide a word of tension, that would be easier. For men, this is also tight. Is it tight if you want to catch it? I usually take that little right angle, just grab it backwards. Well, it's often the spine side to grab, and then in front, grab the lung. But we have a single hole, many times. What about this place? I want to get scissors to cut it again. Well, after cutting it, I found that it is not big and can be cut. And then we cut this, we cut it. Here are some little nourishing blood vessels. It doesn't really matter. If it is cut, it can be stopped. In fact, scissors are still safe. It doesn't damage the bronchial wall. It is, but the drawback is that it is easy to bleed and contaminate the field of vision, right? This is a combination of scissors and an electric hook, which is very good. Hey, no way. Grind little by little. This is entering the stage of grinding at the beginning. Not so smooth. Are you open? It's like this a lot of times. And how about this place? I feel like I'm a stranger when I do it, because the front tricky side can't be distinguished either. The side of the vessel is not very clear, so what you're going to do here is go to the vascular side and do it. I hope to be able to synthesize this fatty artery, divide it out. The side of the tube can be seen more clearly. What about this place? I think this lymph node often because you are often. Well, you carry the lymph nodes, and you take the lymph nodes in one hand, electric hook in one hand, yeah, where else? Here are the lymph node after you are locked up. You give the cistern. Then you take an aspirator and press it yourself. What arterial layer is pressing this? Or the posterior longitudinal muscle arterial edge or something? As long as you. What if you hand it over to the assistant? He is pulling. He's still not easy to cooperate with you. It's easy for him to just pull and pull. Pull the lymph nodes. Shred it. And so I still prefer this place. Relatively one less hand. That robot is in a place like this. I believe it would be better to do. The arm of the robot is very stable. Can pull that angle to that tension. It just kind of holds that position continuously. This combination of the aspirator and ultrasonic knife, very safe. Safer than electric hooks. Yeah, that's right. The best position is actually scissors. Especially this difficult surgery. Its scissors don't do this. This is stabbed bit by bit like this super knife. Then just divide it up, praise and cut it. A lot of it is loose. Scissors is the left hand an aspirator, or take one like your little right angle, would be better. Or if you use scissors. Is the left hand holding the suction device? It would be better to take that little right angle pliers, whatever I feel. Scissors. It's not particularly dependent on particularly high tension. Take it slow here. Slowly find this side of the artery. And it's taking the edge of the artery out little by little. Is this an afterlife branch? Yes, well, it will be born later. I want to separate the offspring. So I can see the epigenetic branch and then what? It won't be accidentally injured, right? Then I will. Along the artery and between this lymph node. Separate this gap. Then dig in. I found it so deep. It feels so tight, mainly because it is going up. It also went up, and then what? It's hard and it eats well. Well, if you do it here, it will be cuddly again. Dare not do it. I think it will be difficult to clean up after it is broken. At that time, the back part of the upper leaf will also be protected. Posterior upper lobe. Right? In a place like this, if you say, you said you had to get this lymphoma out. I guess either open the bottom and take scissors to cut a little bit. Shading it out can achieve something similar to what was said before. This anatomical clarity. Otherwise, that's it. If you burn it, you will be cowardly now. Forget it, just burn it here. Look at this break, just break this one. Break it off and leave the edge inside, right. So this place must be if it is cancer metastasis. There is residue here. Well, of course later. This guy at the back has a 21 checkpoint mutation. It was originally a multi-lock fusion. Multi-lock fusion. If at least. Well, your electric cook is burning down. This move is very handsome. I've never been able to do that. You said it was open. It's an open action. Is it the electric cook? Push down while burning. I think this is a very handsome move. But I never dared to try it. What do you think the gist of it is? Open it and do it like this. That is, you iron it with an electric cook. Then scrape twice. Iron it and scrape it twice, right. That's it. There's nothing down there anyway. Generally speaking. In fact, move forward. If you take a device that records that, to record that open surgery, you'll notice that the open hook is actually quite rough. Right? It's just a little rough. It's very wild and it burns like this. It's not like a hook. What else is there? It's basically done ironing. That scratch, that action, how shaved. Yeah, it's actually less brittle. Yes, sometimes the blood vessel is scalded a little bit. It won't bleed. It's just that, I think. There's no skill in that either. What do you mean by this? Very difficult surgery. There is no skill involved. After you say this, leave this lymph node here. I personally am not very satisfied. But how does it feel? It's hard to sweep this place clean. So it is. I didn't think about it myself. And I was asked if this place was ever going to be relocated. What to do? Consider metastasis before surgery. In theory, should I be open? Shouldn't you be accommodating? Because of the open situation, I am more confident to remove this lymph node myself, without damaging these blood vessels. Get rid of this lymph node. After all, on the right you block then. An assistant will expose good information to you and write it down. Get yourself a pair of scissors and a pair of tweezers, right? Little by little take this lymph node out. I think there is still hope to remove it. So I think sometimes the endoscope. And the perfection of the surgery, the perfection of the local anatomy, it's definitely not as open as it is. Anyway, at least within my own ability, I don't think it has reached the same level as the opening. The same one. Now cut the right middle tubes. Yes, just carry this cut. This is very important. If you don't mention it, the scissors keep slipping. Yeah, so my little pliers work. This is better than that tongue clamp. Because it is finer than tongue pliers, yes. Therefore, when necessary, I still have to replace the information in my left hand with it, like other instruments do provide better. This tension. I sometimes feel the difference between endoscopic surgery and open surgery is endoscopic surgery with less hands. Open surgery always has an assistant. 2 hands to help you. Yeah, one suction in one hand. What's in the other hand? Tweezers or something. The assistant is always these 2 devices. To help you keep doing basic exposure free. Help you suck. And sometimes, maybe 2 assistants. Partial can also provide some tension. Under the endoscope, it is often gone. This lymph node is very well exposed at this moment. The middle lobe between the artery and the bronchus. This lymph node, okay. Later this lymph node felt like it was in the middle lobe. Right, it belongs to. This place is also. Here, what did they say? Just cut a beveled mouth. It can't get bigger. Okay. And then after cutting? Look here and there. Here, Is it that far? It's super far. Ah, right. I'm super far. Really, do this lower leaf sleeve? This is such a situation. Just this middle leaf. It was carried there by the upper leaf. Is it because of this horizontal crack? Well, a lot of horizontal fissures don't develop that well. Now the lymph node is exposed. Mr. Lobe, I interrupted. The lymph nodes you mentioned just now are also exposed. Yeah, so I think this is it. I'll be patient here. Maybe even break it up. Right, so look back now. I don't think the surgery in this place is particularly perfect. And what idea of dimensionality reduction? Well, yeah, and this is the place. It's because after doing it, it's very far away, right? Right, the lower leaf that is very far away. Middle lobe bronchus and middle bronchus, that's a really long distance. Because that's it. Your lower leaf opening is only so long. You have roots on both sides. It's this long in the middle after cutting. There is a gap, you have to force it up. Then wait until as long as one. This middle leaf will naturally go up and the upper leaf will come together. It just sticks together. At that term. This is for this membrane cloth. The tension is greatest there. It's the membrane cloth you match. It's going to be under a lot of tension because the entire middle lobe, it twisted in the direction of the upper leaf, taken by your horizontal crack. This place is easy to leak. This is the middle lobe anastomosis. The anastomosis is on the mediastinal side. And this side is the membrane again. Not very strenuous. Easy to tear. And then there's the tension. So what about this place? We usually open the horizontal crack. So here it is. Just go back and divide this horizontal crack. It's the first time I've seen it. Someone made the lower right sleeve to open this horizontal crack. I think this is a very good idea. So there's a problem at play here. The problem you mentioned just now is the tension of the anastomosis and this blood supply you weren't loosening just now. Fully release the right medial bronchus and right bronchus. This stump. Is this bronchial stump, let it loose completely to reduce tension. I have consulted Shanghai before. Director of surgery in Shanghai. This is the trick here. Just rebuild it. Or do some kind of tracheal surgery. Is blood supply more important? Is tension more important? They say tension is more important. Well, I think this is indeed. If the tension is high, no matter how good blood supply is, it may still leak. Yeah, it sucks. It's hard to grow. And in the back tissue, in 2 days, he was swollen. Right? You see, we do secondary surgery sometimes. For example, if you have an MRI for 2 or 3 days, we have those big lungs. It's a lung leak. Yeah, right. It's been leaking for a week. Not for 2 weeks, not for 2 weeks. Anyway, usually we do it for a week, more or less. It's not okay. There leaks a lot every day. 3 degrees. Then I'm not at ease. You think, wow, is this a leak? Then let's go in and check it out. You can't see there. Maybe which small entrance? Come in and check it out. We're the only ones who have done this. After driving in, the tissue edema is very severe. That lung. Well, what about this kind of leak? It's either leak or pulmonary leak. A small leak on the surface of the lung. Well, you see a little leak on the surface of the lung. You can't even make it up. Where does this needle go? Where is it leaked? After the final replenishment, it still leaks. Leak in another place. Change the place where the eye of the needle leaks. You made up for the original leak. The reverse side of the eye of the needle leaks a circle. Does it work to pull it up and shoot it? Sometimes it's at the root. What we did a few times. It's not particularly superficial. It's rooted. You're not good at shooting. Is it sewing? If you sew, you said absorbable thread. Will that microbridge suture be better? Will it be the eye of a needle if it is so thick? I have 40 prolines. Even if you say it's rough, it's not rough, right? Just be virtuous. Well, you said the situation I have encountered. Oh. So that's when the tissue is very edema. It can't be sewn up. Yes, So you think about this. If you have a lot of tension, wait until a few days later, 3 or 5 days later. This tissue edema is impossible to improve. Well, this tissue edema, I know. You still want that. Put him under so much tension. That must be an easy death. It's thrown here. Thrown. We're still the same. Last two. There's a lot of experts out there who actually don't use this. In fact, it didn't take much time. Don't worry. Take an extra minute or two, right? Anyway, just reduce the difficulty by 1. To put it bluntly, it is yourself. It's better than getting through. It's much better to stab hard there. Look at the 3 canals. It was a very slippery ride. Call over. Right. After this fight, tension problem is solved immediately. Solved. After the fight. That's it. And then actually reverse this thing. I haven't encountered it anyway. Of course then. You see, it's over. After typing this, we will lean together immediately. These two are together. Yes, completely together. Yes, it becomes a line. What's its pipe diameter? Just right. No angle. No angle. Then we are usually 3-0 pros. It's not a gastric tube. Drainage tubes are what we are. Our hospital has bought this drainage tube. It's from the 2 to 30. It's 8th, the 10th, the 12th, the 16th, the 14th. Different diameters like this. We'll use numbers 16 and 14. 16th and 14. No, 14. It just happened to be put on the wall. What is a good way to prevent winding? The anti-winding wire means that we usually make a roll. Look at this. Cut it off. Look at this first stitch. This needle is in the chest cavity, right? It's in the chest. Actually, we got a gauze roll. Got a gauze roll. Roll it up. After rolling it up, throw it at that corner. Once you throw it away, you're left with only one thread. That is, you just need to guard your own hands. Just don't wrap this thread. I have never encountered a mid-leaf torsion before. And I thought, okay. I threw a gauze roll here. Our 3-0 prolines are small frames. 3 little 0 proline frames on this wall. Hello, I'll plug in a question I prepared earlier. It's the preparation before the match. In addition to clearing the lymph nodes to adequately stop the bleeding, release both ends of the anastomosis to reduce anastomotic tension. Pull exposure is also very important. We like to use those little right angle pliers to pull the adventitia of the middle lobe. Very convenient. But there are also some experts who like to use suspension wires to pull. This frees up the left hand. Assist in and out of the needle or pull the wire. Which do you think is more convenient? I haven't used that one. I haven't used it. It's all disconnected. I always take this more right angle and this one. In fact, I myself. If you make this sleeve cut, I actually prefer the one shot. It's this single hole. At a right angle to this little one. This angle it goes in. Follow this gearbox. They all entered the same hole. Sometimes it is inevitable that there will be some small ones. This kind of fight. Go out, that's it. So the sleeve cut still needs to be opened a little bigger, at least 4 cm or more. Put the sleeves, of course the opening is bigger. We'll just add a hole under it. Yes. And then what about our little right angle? It's double, articulated and it's lighter. So what's in front of it? It clips these mucous membranes. What clips more firmly? Easier to clip. So I usually like to take this. Can you move it around? That is, you can put this trick here. Let's move in the direction of your gearbox. You can just kill this one. But if you say, is it a double, single operation hole? What about another hole? Then you're better off right. If you have a single hole, sometimes you get together and get into a fight. And then there's the question of the drain. 2 drains or 1? It's about the placement of the drain. You put a second thin drain or a pig's tail tube. Put it in the back corner. Is this tube below necessary? Haha, I don't need it anymore. I'll put one in and pull it down. Then the needle. We all put needles. They all use small needles, not large needles. Sometimes it's hard to bend a big needle. Sometimes it's harder. The needle feels better. A drain is placed in front of the lung. Put it on the chest top right. A drain. Yeah, a drain. Yeah, just put it in your chest. Will there be fluid accumulation in that corner later? It's not easy to get out. It's okay, most patients are okay. I didn't say there was a lot of fluid accumulation because his lungs are open. Well, he'll squeeze it out when it grows up. We're not special anyway. It's okay, I'm not particularly particular about it sometimes. Of course you put an extra one. Then if there is no air leakage on it, the above one can be pulled out earlier, and the patient is very comfortable, right? There are many experts who like this model. Of course there are benefits. Well, there must be benefits. Well, it just depends on personal preference. We're not so careful sometimes. We're lazy. A tube can be poked in. It's okay as long as it can be drawn out, usually about the same. We are not particularly particular about hospital stay. Said he had to force him to be discharged from a hospital in 2 days. Discharge in 3 days or 5 days, we don't care. If the patient wants to stay for 2 more days, he can stay for 2 more days. Yeah, not so nervous anyway. Our hospital has a model of 1 bed for the whole hospital. Anyway, my own ward is full of patients. I'll just borrow someone else's bed. Anyway, some will be put in, okay? So you don't rush people home. Well, live if you want. Like after you match, I'll let the anesthesiologist take a look. What about the anastomosis in the lumen? Oh, that won't happen. Generally not, it is enough to replenish the lungs. Well, then there will be no air leakage. Well, we anesthesiologists usually use this kind of silicone culture. Then his main him. It won't matter if he plugs the tube in for you anyway. He's not coming either. After all, there are many surgeries, right? So many surgeries. It's 1 main tube, 3 rooms. How can the 3 lungs run back and forth to keep an eye on them? Did you ask the anesthesia assistant to drum up the lungs or something? He looked at the... He won't either. I can't understand him after looking at it for half a day. You see, you still have to go down and guide. I'm anesthetized anyway. Hey, the anesthesia teacher is like this anyway. The more you press him, the more he usually doesn't have an accident. Right? I don't care, haha. If you keep getting into trouble, the anesthesia teacher will turn off the mic for you. Yes, haha. The resources match. Go in and out. Don't worry about it. We insert the needle and this is it. Usually the first needle is at the left-hand end. From the outside in. Then just sew a circle on that bottom corner. Sew this bottom surface this over. So be it. Out you have to go in. Then you go from the inside out when you get there. Then come along. It becomes like this, and the needle so smoothly. Is that what you have to pay attention to? This line can't go through the anastomosis, right? I usually talk about it when I match. This inside and outside. The next shot should be clear from the outside, and then the next shot inside and outside. Sometimes I make mistakes when I'm tired. When I'm tired. When I'm tired. You are not so young. Sometimes I'm tired and confused. Really? Then you are right. You were the first to make sleeve cuts at the beginning. Then you remember it very well, right? I made 4 or 5 during the day. It's 7, 8 or 9 o'clock in the evening. There's also a sleeve cut waiting for you. Many times we are open. Hour. If you say, the patient is under intense conditions. 100 open. What else to do? Open early and sew up. Pull it down right. It takes effort to rescue this. You've got that mid-lobe torsion problem. I used to have a superior lobotomy. We found postoperatively this middle lobe tarses. Some people have a great one that actually arrives the next year. It's the whole year. The leaves didn't open until the second year, just after the upper leaf is cut, and then I fixed this middle lobe to the lower lobe. Just so 2 stitches on the insole. 2 stitches are mostly good, but there are also encounters that are still not open. You look like this. I finally watched this video. I really haven't encountered it yet. This is the twist. But if you do and you know excision, I personally recommend that the horizontal crack should not bully neck on her too much. Don't bully neck on her too much. The artery of this branch. Don't press too hard. Well, some people's oblique fissures develop particularly well. It really might twist after you crack it horizontally. After twisting, can't go back. Just a few months after returning to the ward, CT review were made. Lobe litosities. I've come across a couple. Then I just sewed it all. Sew 2 stitches between the middle and lower pages. It's simple anyway. After sewing, most of them are open, but there are also occasional bumps. Hey, then you still, it's pretty bad. I haven't encountered it yet. So see your last one. I watched this video before. I saw this, and then finally you ended up with this. There is no fixed horizontal column. It is the one that is not fixed between the middle and upper leaves. Fix a needle or too far away here. It shouldn't affect it either. It doesn't affect the tension at this angle, right? Make a decision. Where did you say it was fixed? Yes. You have the anterior upper axillary and the medial middle axillary here. Just sew 1 or 2 stitches farther away. Isn't it still under a lot of tension? Is it still being led by the upper leaf? Oh, I just want it not to be led by the upper leaf. Let it from the position to replace the original lower leaf position. One of the netizens said something like this. Are you worried about it twisting and leaving only one bronchus? The bronchi are still anastomosed. And what about the blood vessel? It's soft again. Could it really be reversed? I haven't encountered it anyway, but do you think it's possible? That must be possible. Then don't say it doesn't match, right? Brother Ming, how many have you encountered? That's not a twist. What should I do when I order my back? That one is horned. It's just a little bit narrow. It doesn't reverse. It's broken. It's blood vessels. It's closed. Pulmonary torsion is blood vessel closure. I'm talking about atelectoses. It's just that the bronchus is a little narrowed in the back. This edem. Lifted or how to get better. Suddenly it gets better, and it gets better again. Vascular torsion, right? Well, I didn't encounter blood vessel torsion. But I think you can choose one of the two. You either reverse or give him a high tension. I choose a high tension. Lower the tension. There should be a risk of reversal. I think your point is before closing. The position of this middle leaf must be placed well. This is a big anti-twist trick. How hot is that so? Put it all away. It naturally is this. Unless you see it twist you. You don't bring it here. That's when the lungs are completely. I think it may have a relatively large range of activities. It's easier to twist after it's already opened. If the location is a normal location, it won't twist. So the point is, on this final stake, be sure to drum up before closing. The location is correct. In this case, most of them will not lose you, right? It's got to get bulging. The location is right. I've seen it before. A video shared by the director. So what they did is they made a top left lobe, and we're done. Probably to put hemostatic gauze in the 7th group. After the discharge, the lung rotated 180 degrees. Head down means dorsal down. I forgot to turn it back. As a result, this lower leaf later died. It's reversed. This video has been shared in many places. Very impressed. Okay. Because the lower right lung is loosening, and when it's loose, the right lower lung can rotate 180 degrees, even more. That is not up. After it is stretched up, it cannot rotate 180, right? Yes, at that time, before it was opened, open it and turn it around. Well, this place will not be transferred to it in the future, right? Tom. What should I pay attention to when gridding? Grid diameter. I have the grid caliber. That's me, that's it. What is this called? This one. The middle tube. Here so wider. And the middle lobe manages itself. This way, the seam is narrower. Then it's so rough. A seam, we don't have this special set either. Then you see after sewing. Anyway, the length here is okay. It's symmetrical, basically. There is a membrane cloth here. You adjusted the caliber of the membrane cloth. The best place is on the trachea side. So thicker on one side and thinner on the other. Make the seam narrower. Just keep your pin distance to the end. For example, in half a circle, your needle spacing matches. But what? The matching of this caliber is more likely to use membrane cloth, film cloth. You can sew. The seam is sparse and the seam is dense. Can it be soft? Can be pasted on. Do you pay attention to the film cloth? The second one is, have bobbed lines been considered for anastomosis of the trachea? I've never used a magnetic wire. I think this line. It's nice to just lie the line and find it. The tension is more even. You talk on both sides. As long as there is no wire in front of you, it's very slippery. All of a sudden the tension is even. Then each stitch is very tight and dense. Bob trot what? Just for this seam. It's easy to tie the knot at the end. Or we're not the kind of thing under the pure gun mirror now. It's under the gun mirror. You always use a knot pursuit at the end to tie the knot, so it's very convenient to tie the knot. So I haven't used the barbed line aspect. One advantage of the slide line is that, you see, before the last few stitches, you don't need to tighten it. It's all this hole. The looser it is, the better you can get in and out of the needle. If you were to bob the line, you would have tightened it. Those last few stitches were difficult. Yeah, the barbs aren't that slippery. You dare not. I dare not say that I put a particularly large amount on myself, right? Well, what should I do if I can't tighten it then? Also ask if there is anything special about the margin. I also feel the margins. How much is this? 3 mm. 2 or 3 millimeters. It feels like 2 or 3 millimeters in narrow places. This is not narrow, about 3 to 4 millimeters. No, about right. 2 to 3 mm needle. What about spacing? Is this the spacing? Didn't you say the margin? Away from that side, the spacing on the sides. I think at least one cartilage for the margin. I have at least one cartilage. At least one cartilage, sometimes even more. Fibrous. Right. I'm afraid that sometimes the tension is too high and the distance is too close. At that time it will be torn and hung up. Well, just tear it off. A little further. It has 4 small eyes. Maybe it can grow by itself. I've never come across such a thing anyway. Well, it will grow after 4 small eyes. That is, but it always feels like it's farther away and dimmer. Bullet comments a bob lines can avoid winding. That's a major advantage. Yeah, that's right. In fact, if you want to cut the sleeves, that's delicate. I myself think that Professor John Lei John in China is a sleeve cutter. Absolute boss. No matter the number of surgeries. Empirically, it's second to none in all skills. So what about us? It may also be a superficial experience. I did what I said. I did some, but it is far from the top level of this industry. There must be a distance. How to remedy air leakage in the blind spot of tracheostomy field. Hey, so the sleeves are cut. The densest one I sewed is the bottom layer. It's the following. At the beginning, the needles go to the bottom of this shop. Go to the corner above. When you come back, turn around and come up. I sewed very tightly in a few places. Sometimes needles. I went back and forth to that place for a long time. It goes back and forth around the needle. Just because I think that place was the needle. That place. First stitch, second stitch. The back side is the easiest to leak air. Because if you get a needle on your side, wouldn't you be in the bottom corner? It's actually the bottom corner going up. It's about 2 or 3 millimeters. 3 or 4 millimeters. And then, then go to the surface of this bottom surface. Go back and forth. Right? Over here. If there is an egg in the future, that's the hole that's invisible. Invisible place. That can't be made up. I feel like I can't get it up. That's why it's so tightly sewn there. I just hope this place doesn't leak air. Here's the point with the most tension. Is it near this position where you tie the knot? Yeah, that's right. That is if you were giving him according to the original angle. He should be a little further down here. More on heart noodles. It's almost there. It's pretty close probably. It should be this location. This is closer to the membrane cloth. This place is where the knots are tied. It should be that the cartilage ring has just arrived after the membrane has been cloth. Go ahead and take 1 to 2 stitches. Well, it's better to just hit the cartilage. Hey, the place of the membrane cloth is tension. Process of maximum tension. Can't unload this tension to the membrane cloth. So you open this trick with this horizontal line. I think it's very good. Then someone on this bullet comment asked, like the upper and middle leaves of the fruit stitches here. It just doesn't tighten. Just whether the knot is tight or not. It has a length. Just hang. Will that help? There is just no tension. It's twist resistant. Sure. But how long this line stays may have to be studied. Is that okay? I think there's a way. Yeah, pretty good. Okay. But I want you to say reverse it and say it back. Some people have leaf fishes that are good. It's all about the roots. Then you will tie him up. Is it possible? He's only that long. Oh, perfect. Does it look like there is no air leak at all? Yeah, it's a little stingy on the surface of the lungs. A bubble in the eye of a stingy needle in the parenchyma of the lung. Okay for my organization. And then hey. When the patient woke up. Then move it to the bed. A cough and a leak. He startled me. I said, why didn't it leak when I was out of breath? Why did you leak it now? Oops, no, don't go to the recovery room yet. Let me take another look. Then it doesn't, and then for a while. Slowly getting smaller. It got smaller and then it disappeared. It turned out to be connected inside a heart. Just normal patients. You probably don't pay that much attention to this patient, do you? Just one more look. And I came down. Sliding line, not strength. Don't use too much force. Just ordinary. Just watch it tighten. Just like you and I feel the tide with that. Especially since we are the 3 leaders. Sliding suture tricky. Well, that's tough. Not strength. You won't pull. Won't break the knot. Anyway, tie it with your ordinary silk thread, just about the same strength. Sewn too tightly affects blood circulation. Yeah, but I don't sew it particularly tightly. Fine. Then film cloth to film cloth. Cartilage to cartilage. Membrane cloth to cartilage. Of course, it can grow a good trick here. What is the trick here? It's just so long. In theory. There are many times when I feel, even sometimes, you don't feel particularly satisfied with your mix. It can also grow. Yeah. Not good for the lungs. The lungs are definitely not growing well. This one. It's a single lung again. When to sweep the lymph again. After scanning the lymph, we don't get used to it sometimes. I'm finally done. End. Don't close your chest right. Well, I forgot to ask Louis to replenish his lungs. Sometimes the chest is closed. Oh, it's still a single lung. Say, oh, Mom, this is double lungs. Double lungs. Oh, hi. It's not that the lungs don't grow, okay. Right then. Cross the bed. The patient coughs again. That's not grunting, it's all here. Okay. Break a few stitches to reinforce. Intermittent stitch reinforcement. I'm not reinforced. Well, sometimes experts like reinforcement. It used to be when we opened the surgery. When we do open surgery for anastomosis. The teachers were teaching us about open surgery. It's all reinforced. And there is this special tension reduction needle. Knotted in a few fixed places. Don't let the tension of your anastomosis be too high. Focus this tension on the tension reduction needle. Where's your tension reduction needle? So on the edge of this cartilage. Just a little further away from the cartilage. I also learned from in this place. Separation. Hour. Suddenly. It looks good. Then tie the knot. Not slide line through. Not through. Pores have shrunk significantly. That won't happen. Cricket cartilage hard. He said that through good means. Maybe the force is more even. If you pull it. Every single one of these. This force is relatively uniform. If you so light now, you can easily tear it apart. Is to do tracheal anastomosis. We're also in the era of open surgery. In fact, this punctuated anastomosis was also done. Not all of them. All of them start with 3 zeros, because our old professor, sometimes when they teach us, they don't have 3 zeros when they make sleeve cuts. It's really. So they have intermittent sutures. Sometimes we followed some professors at that time when teaching us to operate. It's just intermittent. The sleeve cut is also intermittent suture. Some professors just sew it well. Not only can he cut the sleeves, he also does some in stitches to ensure that there's mixing port on both sides. The alignment is more even. Just don't have nesting. Well, I feel that sometimes. U-shaped? Yes, entering the room. Just enter the room. Breaking in and suturing it is not. It becomes an aversion. Yeah, right. Well, it will turn out after entering the room. That's when this fit is particularly good. This trachea is valgus to the trachea. There is no tracheal stump in the mucosa. But if you sew continuously, it's actually more or less. It will be in some places. There is a nesting situation. That is, the small pipe diameter will be put into the large pipe diameter, not necessarily a pure one-ended anastomosis. It's a case of a little bit of shingle nesting. Is the spacing large? It is prone to nesting. It will be better if the spacing is small. A little better. Yeah, that's right. But I think it doesn't matter that much anyway. You don't need to pay special attention to saying that it is nested. I feel okay. Do they have teeth? Are they horizontal or vertical? The teeth are horizontal. Like teeth in front of a blood vessel. Okay. It's just perpendicular to the axis at that end. Yes, it's a normal vascular clamp like a vascular clamp. The normal vascular clamp kind of sideways and then. Practice using an ultrasonic knife. I am not a master of ultrasonic knife. I am a low hand of ultrasonic knife. I like to use electric hooks. So humble. Master of ultrasonic knives. That Wang Ming teach me next time. I don't know how to use ultrasonic knives either. Invite. I also like to invite the master of ultrasonic knives. Oh, in other words. Professor Fan is fine. Professor Fan is an ultrasonic knife master. Yes, absolutely. We belong to the ultrasonic knife low hand. Anyway, generally speaking, it is an ultrasonic knife. It still works, right? We use less to grind directly on the blood vessel. But this limb sweeping basically does not rely on ultrasonic knives. Anyway, it's just copying and moving places. Don't keep burning in one place. Sometimes it just happens to be pushed to where you burnt. Just accidental injury. We are all burning. While burning, move, burn, and tear. You see, tearing while burning. Local late stage after lymph node dissection. What are some good ways to avoid chylothorax? Would you block the thoracic duct prophylactically? We don't do it. Don't do preventive this. And if you have an ultrasonic knife, actually, you just make sure you copy every one of them down, rather than torn off. That's basically. I feel that the incidence of maintenance is relatively low. Not too high. And that can only be seen but not learned. Who says you can't learn? Haha. That's definitely something you can learn. It just takes hard practice. Yes. Our video didn't go backwards. There's no fast forward, there's no fast backward. And then we're done. And I've prepared a question for you. On concluding questions, I'm going to read the question. What do you think? Sleeve under single port endoscope. What are the key points and difficulties? How to respond? This is a general question. Point? Okay. Well, the prospectus is the point. Off full dissociation is the point. Because after being fully dissociated, this basic activity is good. If you match, it is convenient for you to enter and leave. Right? Good activity. You can move around. Find the right angle like yours. If it's difficult, well, your size should match. So evenly. You can't wind it. Hey, what about the one that doesn't wind? I think getting that little cotton ball, throw a needle into the chest cavity, and you just stick that needle in your hand. That line? Hey, that's not too easy to go around, it's really much better. There are 2 lines in it. Anyway, I don't care about myself. Often sewing. One gets tangled up with another thread. Or the 2 wires are wrapped left and right. Completely confused. I just like it. Wrap a thread first. Get a little cotton ball. And he throws this ball of gauze to the side. I think this feels better. Then wind or something. And then there's the bottom layer. I like it a little denser myself. It's best to do it all at once to make sure it doesn't leak. Anything else? When there are the last few stitches left, can you loosen it up a bit? Try to put this long, and sometimes they tear it apart. It may be easy to sew if you pull it away. Nothing else. Practice makes perfect. Add a hole. That is, if you feel awkward about the single hole. You can add a hole or make the opening bigger. This is generally speaking. A bigger opening is king. When we were learning surgery at that time, open surgery, right? It started with open surgery. G may have started out like you. I was also open at first. There was no chief surgeon at that time. It's all about the system. Yeah, we started out with open surgery. Open surgery, our superior doctor. When you can't do it, when you want to ask the superior doctor to come on stage to help, first thing the senior doctor does when he comes up is to extend the incision. No matter how big your mouth is. The superior doctor said, why the opening is so small, I'll extend it for you first. After extension, sure enough, you think the director is awesome. After coming up, it's done. But the first thing he did was lengthen the incision. I think you can't show your mouth. So I think doing endoscopy is like this. That is, if you just start doing it at the beginning, the opening might be bigger, it doesn't matter. Or you can add a hole under it. How about 2 holes? What about just 3 holes? Right? It doesn't matter. Get used to it and reduce it slowly. You can make a hole without it, okay? Well, so it's something else, it doesn't seem to be anything. Anyway, this person is more suitable for sleeve cutting. There's not too much invasion of the blood vessels, right? Blood vessels are still relatively easy to free, whether it's veins or arteries. So it's not much to talk about difficult sleeves. Sleeve resection. It's just a regular sleeve resection. It's just that the cutting position is the lower right chest. I see this sleeve cut shared by many experts in the group. It's very difficult. It involves the blood vessels and the trachea. This metastatic lymph node, violation of these issues, well, that might be even more difficult. The artery needs to be blocked. Okay, there's also this Professor QU in front right. Professor QU. Do a double cough. Well, your blood vessels are also in prison. Organs are also in prison, right? So it gets harder. So expect more experts. Professors share their own experience. Successfully learned more. You see about winding, my method is different from yours. It's just that I thought about it before. Wrap a gauze roll and throw it into the chest cavity. It was troublesome later. Just straighten the unsewn needle. Put it on the inside of the back. In that case. This is not the case when the other wire is wound. My winding used to be when it first started, mainly by myself. And then I summarized it. The reason for this winding is you just didn't get it in the right place when you pulled it out. Pull the needle out of this coil. You just pull the needle out of the coil and it doesn't win. And I noticed that when you pull out the needle, it's always this needle. The needle pulled doesn't come out. It's this needle that's pulled out as soon as it's done. I have to come out every time. Because I'm not coming out. I don't know. Am I in this coil? After I came out, I turn this coil with an aspirator. Just take a look at the structure of the coil inside. It doesn't work to get an injection from the outside. Because I am just a thread, you know? Just a thread. So when I put in the needle, I designed it. I'm going in here, then immediately pull out this wire. He's just like, let's say I'm pulling the thread backwards. I put the needle in from the side of the head. Pull it immediately after sewing, he won't go around. And sometimes there's 2 wires. I'll tie it. Then you will be confused. Right. So think of your way in your head. Every time you enter, come out and take a look again. Then go in after confirming it. Your way is better, if you can do it without winding. This saves a lot of time, haha. Is this fast? I am unhappy. I'm not fast. But I don't know what to say. With Brother Ming, I still learned a lot from talking about this. Lymph node dissection. Look at this from Brother Ming. The way to break the lower lung tolerance first. This is different from what I used to do. Sure enough, this esophagus rollover is better exposed. Right? Mainly too modest. Still a lot of growth. Teacher, do you have anything to add? Single hole sleeve cut. Nothing special to add. Here it is. It's a matter of reversing. I actually have 2 questions. It's just a matter of reversing. I actually can't answer this. I think so myself. It's the easiest. I'm just relying on the line. Pull these 2 tricky together. Okay? So are many experts. Just pull together. No matter how far. In fact, if you force it, how far do you say it is? Your lower leaf sleeve swab. You can pull up to the heel as well. Go to that place. Match it. But I always feel that this tension is relatively large. Because if the lower right sleeve leaks, the incidence is still relatively high, don't you think? It's simpler than this. For example, our upper right sleeve is leaking. The incidence may be higher. Yeah, I think it's because maybe it's with this one. The tension itself is relatively large. When you match the 2, it didn't come together. Or rather hard to put together. Because of the choice, just turn it into an interleaf fissure. Well developed. Such a patient. Because of the horizontal crack. It's just that his state has become. It's equivalent to an interleaf fissure. Well developed. Such a stay. Right? So each of these patients has to be fixed. I don't think so either. The root of this fissure is near at artery. This location. Securing 2 stitches will not cause an increase in tension. It can also play a certain anti-twisting role. I think it's possible. But there aren't that many opportunities. Can't try. You can try it next time. See if it will. Teacher Lou, someone asked you, can you chat about your upbringing? How can I be so outstanding? Bullet comment. Growth experience. How did you do it so well? What is the growth experience? Growth experience times dividend. We were old then. At that term. We master's students are looking for jobs. Find a provincial unit. After graduation, you can't go to work in a provincial unit. They want you. No PhD? Nah. We didn't have many masters at that time. I remember posting the Sci article at that time, right? Or send a domestic one. You can also graduate. They are not all Sci articles now, right? Okay. This so. It's just getting more and more curly now. How excellent. Then you have to be good now. That has to be excellent. We could sometimes paddle back then. Our Teacher Lou is too modest, haha. Okay. The superior lobe bronchial opening occupies deep within the epigenetic artery. Preoperative POW. Preoperative PETs are good. Is this lymph node good? It's in transfer. There is no hint for this one in the hilum. This place is positive. But what about this one? We're talking pathology anyway. There will be pathology in 2 days. If you have the chance, let me share with you what pathology is. So, I sometimes come out of surgery. It's the other way around. It's for patients who are slow. Your lymph node dissection. Can you achieve the same level of openness? Actually, it's impossible. But the effect may be similar. This is because maybe your lymph nodes were dissected. You don't have to be that tall sometimes. You know, like what? You are like this lymph node we have today. Upper lobe. Between the bronchus and the branches. This lymph node is actually drilled into the entire front of the upper lobe bronchus and the back of the pulmonary artery. It's a single node in the entire hilum of the upper lobe. What about the surgery on your lower right? You're going to remove the lymph nodes from the superior hilar lobe right to reach this level. Then I believe, most of the time when doing lower lobectomy, will not scan this lymph node. Open surgery, if you will, is more difficult. I'll take this place when I arrive. I do often sweep it away. Because of open surgery, sometimes we still make a hollow out. Sometimes, for example, if the upper left lobe is open, I will put this lower lobe dorsal. An inferior lobe anterior muscular body segment. It's this lymph node on the lower left that has been hollowed out. And then we also sometimes find there are some patients he has metastasis, that is, the cross of the upper leaf becomes, something like this. This place is called upper leaf cross. We group it. Send pathology. Sometimes it comes back positive. There is indeed. But how? I find it so difficult. You can see here the tongue and the hypopharyngeal bronchus. This lymph node right. This lymph node and this patient are all cleaned up. Sometimes it doesn't clean up. It comes from this middle lobe artery. It's growing in this stitch. Right? You sweep it all? Nope, like doing. But if you must sweep him, that would be equivalent to, you take this artery in the middle lobe, put this bronchus, hollow it all there. Just this way of meeting teachers. That might sweep it away. Endoscopic. I feel like a lot of times I can't do. Open up, I have confidence. Because what do I choose sometimes? You severed an artery in the middle lobe. So that's what it's called, the lateral segment. Lateral segment. The small outer one is broken. After it is broken, dig that inside in. You want to save that lateral segmental artery. Your lymph nodes won't come out. So in this case, should the surgery be changed? Do you want to do this open surgery? Should these arteries be severed? So let's say this person is watching the lymph nodes go. Then branches. This place is already in prison. Even if you are open. What if this place just can't be divided? Well, you'll absorb the epigenetic artery. There is still value in the sacrifice. Meaningful. Saved is a negative. However, make a freezer. Do you want to freeze it? Just freeze it. Okay, right? Make it frozen. But sometimes I don't know. Maybe freezing is a good option. Oh, our hospital rarely accepts freezing in 2008. There is a limit to the number of times it is frozen. You can't be bothered by familiar people, can you? He said I would make a freeze here and a freeze there. This lymph node was scanned and frozen. That lymph node was scanned and frozen. He's crazy. He said, look at this. People make a lawn and send a virus. You send it 3 or 4 times. You can't tease us. Yeah, right. It's just that sometimes there are compromises. You said the surgery was perfect. I think there is a compromise. Well, there is a compromise, so let's go up overall. Okay, no bleeding crowd. Someone asked me on a bullet comment. Blunt separation of 4 groups of lymph nodes. Will there be a small vessel communicating the superior vena cava? Bleed. Because I have blunt separation on one side is watching. Generally, you can see it when you are blunt. Here's a little one. Then use an ultrasonic knife to slowly slow it down to coagulate it. And then after it coagulates, then I saw a small one again. In this case, it is still relatively safe. I think blunt dissociation is safe. Safety. My real name authentication, I just tried again, haha. Sure enough, aham. Okay, teacher Lou, it has been more than 10 minutes. That's it. I didn't have a good dinner. I'm going to read the closing word, hour. Thank you, Director Lou, for your wonderful explanation. I believe you will have many new questions and valuable comments. You can follow up, official account and live replay video published by the website. Leave a message in the comment area. You can also put the topic you want to explain live. Write in the comment area. Our third issue of Big Coffee Connection surgery video explanation live broadcast tentatively scheduled for July. That's next Thursday night. Stay tuned.